glomeruli are filtered and then passes through, what are all the structures it passes through, and how does it come out. So these are the questions or the answers that are expected for this question. So can anyone say how many of you know the histological nature of the kidney? When you make a cut section of the kidney, how do you describe the histology?
It has got a cortex and the medulla.
Excellent, excellent. It has got a cortex and medulla. Which forms a major part, the cortex or the medulla?
Medulla.
Cortex forms the major part.
Cortex forms the major part. Why cortex forms the major part?
It has the long
Got zone.
take part in.
It is the filtering unit. Okay, it is the most important filtering unit. The medulla is only a concentrating unit. Okay, so the filtering unit, you need a large number of nephrons to filter the plasma to form the tubular filtrate. The fluid that gets filtered and comes into the fluid is the tubular filtrate. Okay, so that has to go through. So the cortex is the major portion and it dips into the medulla. So if you see the structure, this is the picture. Okay, so these are all the terminologies which normally as an undergraduate as well as a postgraduate in anesthesia, you people are not exposed to or taught of. This is mostly the urologists and the nephrologists will be knowing this more in detail. So if you see here, this is the cortical structure, and this cortex dips into the medullary portion like a triangle, and these triangular faces are called the renal pyramid. Okay, what is the name for the tip of this renal pyramid? This triangular structure which is dipping into the different colored portion, which is the medullary portion. Can anyone tell me what is the tip of this triangular renal pyramid is called? There is a one which has been marked in a circle here also. It's called the renal papilla. Okay. Have you heard of papillary necrosis? One of the causes of hematuria?
Yes, sir.
Yes, sir.
Yes. So this is the papilla, and then these pyramids, they drain into the calyx. Okay. So this pyramid which drains into calyx initially into a smaller portion called the minor calyx, and many minor calyx join together to form the major calyx, and the major calyx goes into the renal pelvis, and the renal pelvis continues down as ureter. Okay, so this is the normal histological description of the path during. So the cortical nephrons do the filtration, then the nephrons conduct the urine to the distal portion, which is mainly situated in the medulla, and then the urine is filtered and then passed through the papilla into the calyx, and through the calyx into the pelvis, and through the pelvis into the urethra. So that is what this question, urine conducting parts of the kidney, describes. So the cortical nephrons, renal pyramid, the papillae, the minor calyx, major calyx, renal pelvis, and urethra. Okay, that is how the urine goes down. So if you describe that, the renal parenchyma is divided into two main areas, the outer cortex and inner medulla. The cortex extends into the medulla, dividing it into triangular shapes. These are known as renal pyramids. And the apex of renal pyramid is called the renal papilla. And each renal papilla is associated with a structure known as minor calyx, which collects the urine from the pyramids, and several minor calyces merge together to form the major calyx, and urine passes from the major calyx into the renal pelvis, and from the renal pelvis urine drains into the ureter, which transport is to the bladder for storage and then further evacuation. Okay, so this is the channel through which the urine goes out of the kidney into the bladder. Now the next question is, describe the anatomical position of kidneys. Where are the kidneys situated?
Kidneys, retroperitoneal organs.
Fantastic, very good. And what level? Retroperitoneal means it can be from diaphragm to pelvis. Which level it is situated? Which lumbar level? Which lumbar vertebral level it is situated?
L1,
L1, L1.
L1 to L3. Very good. Okay. So
right
kidney
kidney
is
is lower than the left.
retroperitoneally placed in the abdomen on either side of the vertebral column. Okay. And it is from T12 to L3, not L1 to L3, but T12, one level higher up, T12 to L3. But the right kidney is often situated slightly lower. Why? Because of the presence of the liver on the right side. Then each kidney is approximately 3 vertebrae in length. Roughly, an adult kidney will be to the extent of the length of 3 vertebrae. Adrenal glands are situated immediately superior to the kidneys. Now describe the structures which are in relation to the kidneys. The kidney has got other organs which are in relation, which are different on the right side and the left side, isn't it?
Sir.
So what are the structures? How do you describe the relationship of other organs to the kidney? And what is that significance to us?
Superior,
Right
right
side
side
superiorly
superiorly it
liver.
is liver, sir.
Left side is spleen.
Posteriorly, both sides there are 3 muscles: psoas muscle, quadratus
Quadratus lumborum.
lumborum, and
Erector spine.
Rector spine.
and the 2 nerves,
Correct.
iliohypogastric nerve and
Yeah, you,
inguinal nerves.
so we can say the anterior relationship and posterior relationship, okay? Because it's a retroperitoneal structures, we are not much worried about medial or lateral relationship. What are the structures anterior to the kidney? What are the structures posterior to the kidney? On the left side, if you see, anteriorly suprarenal gland, spleen, stomach, pancreas, left colic flexure, and jejunum. All the intestinal portions are there close to the left side kidney. Posteriorly, it is related to the diaphragm, 11th and 12th ribs, psoas major, quadratus lumborum, and transversus abdominis, subcostal, iliogastric, and ilioinguinal nerves. So these are all the relationship for the left kidney. For the right kidney, again you have the suprarenal, but liver is there, the major organ above the right kidney, anterior to the right kidney. Duodenum is there, right colic flexure is there. And posteriorly, again it is related to the diaphragm, partly under the diaphragm, 12th rib. Again, psoas major, the same 3 muscles and the same 3 nerves are related to that. Okay, so this is the relationship. So any inflammation or pain, it will be reflected along the lower part of the ribs. Okay, any swelling, perinephric abscess or an inflammation, all these things will be, what is the angle called formed by the psoas major and the ribs? Quadratus lumborum. These muscles make an angle with the lower rib, 12th rib.
Renal angles.
Renal angle. So we always check for the renal angle tenderness whenever there is a suspected inflammation on the right or left kidney. If you press on the renal angle, patient will have severe pain because these nerves are traversing there, and any swelling or inflammation will produce severe pain when you press in the renal angle, which is formed by the 12th rib and this muscles which are adjacent to that. Okay, right. What is the blood supply of the kidney?
Right renal artery, left renal
Left
artery.
artery.
Artery, artery. Where do they arise from?
Abdominal aorta, sir.
Aorta. It's a direct branch from the aorta. Fantastic. And do they arise at the same level or at a slightly different level?
Different level.
Different level, because the right kidney, as I told earlier, is at a lower level because of the liver. So right renal artery takes origin at a lower level, left renal artery takes origin at a higher level. So the kidneys are supplied from renal arteries, which are direct branches from abdominal aorta, immediately distal to the origin of the superior mesenteric artery. The closest major artery is superior mesenteric artery. why should we know about the renal arteries or the major arterial supply of the kidney? What is the importance to us as anesthesiologists?
In case of transplant,
Hmm.
it is useful, sir. The
Okay,
length of
very
the
good.
artery.
Okay,
In
any other reason?
case of vascular surgeries, superior, if suprarenal graft, infrarenal graft, sometimes we also
Clamping, yes, very good. So, in cases of aortic aneurysms, we always call them as suprarenal aneurysms or infrarenal aneurysms. And depending upon the location of the aneurysm, we may have to clamp the aorta. So the aortic clamp, if it is placed above the renal artery, what is the importance? What should we do as anesthesiologists to preserve the function of the kidney? What will happen if you blindly clamp above the renal artery origin? What will happen to the renal function?
Deteriorate.
nil urine output.
AKI.
Correct.
Pre-renal.
Yeah, it will go in for acute kidney injury because of ischemia. Okay, so we must make sure that we preserve the blood supply. So we have to take a graft or a conduit, insert it above the clamp, and bring the tube and insert it into the renal artery so that we can give a continuous perfusion of the kidneys. So suprarenal clamping carries more risk of damage to the kidneys if not properly managed. Whereas infrarenal aortic clamping, when the aneurysm is lower down, it is much more safer. So that is the reason why we should know what is the blood supply, especially arterial supply going to that. And so, as I told earlier, the renal artery is a little lower in the right side, and it is longer because it is very close to the vessel and crosses the vena cava posteriorly. And the renal arteries, as soon as they enter, they divide into two branches, anterior and posterior divisions. And the anterior division carries the maximum blood supply of 75%, whereas the posterior division supplies 25% of the kidney. So, and the major renal artery, after anterior and posterior division, they divide into 5 segmental arteries which originate from these two divisions. Okay, and each segmental artery then divides into interlobar arteries and are situated on either side of the renal pyramid. What we saw earlier, the dipping of cortex into the medulla is called the pyramid. So the renal artery as interlobar arteries goes on either side of the renal pyramid, and that is the reason why I thought we should know about the internal anatomy of the kidney. And these interlobar arteries undergo further division to form what is called arcuate arteries, which means they turn like an arch. That's the reason why they are called arcuate arteries. And at 90 degrees to the arcuate arteries is the interlobular arteries. So interlobar arteries continue as arcuate arteries, and then they become what is called interlobular arteries. And these interlobular arteries pass through the cortex, dividing one last time to form what is called the afferent arterioles of the nephron. Because the smallest branch is the afferent arteriole, which goes to enter which part? The afferent arteriole ends up where?
Bowman's capsule.
Glomerular capillaries. Okay,
Glomerular.
afferent arterioles further divide and become what is called the glomerular capillary tuft. Okay, so the afferent arterioles form the capillary network, the glomerulus, where filtration takes place, and then the capillaries again come together to form efferent arterioles. So this is one situation in our body where a capillary network. Normally in other parts of the body, what is the difference between this kidney capillary system and the other parts? When
Artery
when the capillary system ends up, how does it get drained?
continuous venous system and
venous system.
venules
The
and
artery will
veins.
be at one end and it will branch out into multiple capillaries and then it will drain as venous system. Okay, after the oxygen has been taken out, it will drain as venous system. So in other places, the capillary system is supplied by the artery, drained by the venous system, and it is mainly for giving the nutrition and oxygen. Whereas in the kidney, because it is a filtering function, it comes in as an artery, goes out as an artery. So we call it as afferent arteriole and efferent arteriole and not a venule. That is a very, very important point which all of us should remember. Okay, it forms the afferent arterioles, which is the smallest branch of interlobular arteries. Then it forms into capillaries, and after the filtration function is over, these capillaries again join together and become efferent arterioles and not venules. Please remember that point. And in the outer two-thirds of the renal cortex, the efferent arterioles also form what is known as peritubular network. After forming a single efferent arteriole, again it branches and forms a capillary network which goes around the tubule and supplying the nephrons with the oxygen and nutrients there. So at that level only, its function is for supplying oxygen and nutrients to the tubules so that they can function normally. Whereas in the glomerular space, in the glomerular capsule, its main function is only filtration. Okay. So how does that filtration take place? The inner third of the cortex and medulla are supplied by long straight arteries called the vasa recta. What is the importance of this vasa recta? What is their function? Initially, the capillaries around the tubules, they are mainly for supplying the oxygen and nutrient to the tubules. After that, they continue as vasa recta. What is the role of this vasa recta?
Concentration of urine.
Countercurrent metabolism.
Countercurrent mechanism.
Yeah. So it is mainly helping to remove the excess water because body is almost filtering 180 liters of plasma every day, out of which we are going to pass only 1 to 1.5 liters of urine. So the rest of 179 or 178.5 liters of water has to be reabsorbed. We cannot pass all the 180 liters in one day. So that function is done and that is helped by this vasa recta. So this much of detailed knowledge about the blood supply to the kidney is very important. How the main arteries divide, where all it go, and there are some more peculiarities about this. What is the describe the anatomy of the renal vasculature in relation to nephrons? This is also very important to understand its function. Earlier, I have told you how the arcuate artery becomes the afferent arteriole, then becomes the capillary tuft, then becomes the efferent arteriole, immediately gives a capillary system for the tubules, then continues down as a vasa recta. In addition to that, is there any other branching which is of importance? From the, I can give you a clue also, the efferent arterioles, apart from forming the capillary for supply to the tubular system, it also has another important function in relationship to the distal collecting ducts of the nephron. To regulate the blood flow into the kidney. How many of you heard of the juxtaglomerular apparatus? Have you all heard of that terminology? Juxtaglomerular apparatus.
Yes, sir. Yes, sir.
Which contains renin.
Which stimulates the
maintenance of blood pressure.
How is it maintained? How is the maintenance of blood pressure? How is it done by the juxtaglomerular apparatus? What are all the components in the juxtaglomerular apparatus?
Sir, macula densa, afferent arteriole mesangial cells.
It senses decreased blood flow to the kidneys, sir.
Very good. Okay. So what happens?
Renin angiotensin mechanism.
But
Then
you
the
should be
stored
able to
renin,
explain it correctly.
Stimulates RAS pathways.
then the stored renin molecules will get released into the circulation, sir.
Very good. Where is the
Reduces
renin molecule? Which one releases the renin molecules? Which
It
part
is
of
macula densa.
macula
Pericardial.
does
It
macula densa
stimulates.
release renin?
No, sir. It's macula
Hmm.
densa gives signals
Sensor.
and
It is only a sensing unit. It
yes,
senses two things. One, whether there is a decreased flow. Second, whether there is a decreased sodium level. Both these things are sensed by macula densa. Then it will stimulate the afferent arteriolar endothelium. And the renin is released from the afferent arteriolar endothelium into the circulation. Okay. It is not directly released from the macula densa. So macula densa is only a sensing unit which immediately will give a signal to the endothelium of the afferent arterioles to release the renin, which is a small peptide protein, and that will enter the circulation. And where will it go? The renin
It goes to the lungs, sir.
immediately lung. These are the steps which you should be very, very thorough and you should be able to understand. Once you know that, you will be a master in your renal physiology. So the renin goes
converts
first to the liver.
angiotensin.
It is first the liver, hepatic conversion of angiotensinogen into angiotensin 1. That is what is happening by the action of renin. It is the first action of renin is to go to the liver and convert. Liver has a storage of angiotensinogen, which is again a polypeptide, and it is cleaved and then converted into angiotensin 1. This angiotensin 1 will get released into the circulation and that will go to the lung. And there, what is the enzyme which is going to convert this angiotensin 1 to angiotensin 2?
Angiotensin converting enzymes.
Converting enzyme, ACE. Okay, so that conversion happens only in the lung. So please remember, renin does not go directly to the lung. It goes first to the liver, converts angiotensinogen into angiotensin 1. Then angiotensinogen 1 is carried to the lung where ACE is present, another enzyme, which will further cleave that and convert it into angiotensin 2. And this angiotensin 2 is the active component. And that will come again to the renal system and cause constriction or increase the pressure and try to improve the blood flow to the glomerulus. Okay, that is how the whole system works. So the glomerular afferent arterioles are derived from interlobular arteries, as we said earlier. The glomerular capillaries then coalesce to form glomerular afferent arterioles, which then branch to form the peritubular capillary network. So if you see, there are two capillary beds in series. That is, one capillary bed by the glomerulus, another capillary bed is the peritubular capillary network. So between these two, separated by the afferent arterioles, this is unique to the renal circulation. And the blood flowing to the glomerular capillaries has got high hydrostatic pressure. So that helps to filter the plasma to form the filtrate in the Bowman's capsule. Okay. So the glomerular capillaries are high in hydrostatic pressure. On the contrary, the peritubular capillary network has got more colloids because proteins are not allowed to be filtered. So the protein which is there in the plasma will be coming to the pericapillary network along the afferent arterioles. So the colloid osmotic pressure is high following the filtration of protein-free fluid in the glomeruli with a low hydrostatic pressure. So when the pericapillary network has got high osmotic pressure, what it can do? It can absorb the fluid from the tubular system. Whatever filtrate has come down into the tubular system, because this has got a high colloid osmotic pressure, it can reabsorb. That is how the 180 liters of plasma which is filtered gets reabsorbed because in the glomerulus there is a higher hydrostatic pressure to filter the fluid. In the pericapillary network there is a more colloid pressure, osmotic pressure to reabsorb that fluid, and that is how the, so as we say, you give in this one hand and take away the other hand. Okay, like that. One picture they will say we are giving free dress to some people, and as soon as the material is handed over, somebody will collect it back from the recipients in the side way. One of the pictures that used to be the comedy that is being done. So it's the same way. Filtration is happening at the glomerulus, and reabsorption is done by the peritubular capillary network along with the, because of the high osmotic pressure. So this favors reabsorption. And if you see this picture, this is the can see this. This is the interlobular artery which continues as afferent arteriole. Okay, and then after forming the capillary network, it comes out as efferent arterioles, and then it goes, one branch goes here to the juxtamedullary nephron also. So the juxtamedullary apparatus, as it is called, is a combination of the distal convoluted tubule and the afferent arteriole with a branch of efferent arteriole also. So these three structures together form the apparatus, and this is how the whole filtering happens. Here the afferent arteriole, you can see it is got a colloid osmotic pressure of 10, hydrostatic pressure of 108, and then because of that it gets filtered and it goes down, and when it comes here, the GFR is about 125 ml per hour into the Bowman's capsule. Okay. After that, the pericapillary peritubular capillary, you have the hydrostatic pressure is only 13, whereas the osmotic pressure is 36. So because of the gradient, you get the, so what gets filtered here is reabsorbed at this level. So these two pictures will tell you about how does it happening. So in the juxtaglomerular region, different arterioles branch after leaving the glomeruli. Some of these branches contribute to the pericapillary network surrounding the loop of Henle and collecting ducts in the outer medulla. And then these branches make no contact with the proximal tubular tissues, as this case is in the renal cortex, but penetrate deep into the medulla before further branching. So the reason why it continues as a vasa recta, as I told you, it is going clear the medullary region, and it forms the thin loop of Henle and thick loop of Henle as vasa recta to cause more concentration. This gap between the collecting duct, the loop of Henle, this portion is called the medullary interstitium. Okay, so this interstitium should have a higher osmotic pressure to reabsorb whatever fluid is going into the tubule, and this is a very, very important thing, that this should be maintained at a higher osmotic pressure so that it can absorb the fluid that is passing through the descending ascending loops of Henle and the distal tubule and all these things. Otherwise, we will be passing a lot of water and we will have excess diuresis. Now coming to the renal tubular anatomy. This is another important thing to understand how some drugs or other things can, pathologies can affect the function of the kidney. So what we saw earlier is the renal blood supply, how that is important. Along with that, we should know what is the renal tubular anatomy. Can anyone describe what are all the components of the renal tubules? That is the nephron, starting from
Proximal convoluted tubule, loop of Henle, distal convoluted tubule, and collecting ducts.
Collecting ducts, very good. So the glomerular filtrate flows from the capsule, glomerular capsules, into the proximal tubule, which consists of two parts. The proximal convoluted tubule, as it names, it is a serpentine-like structure, bending many times. That's called the convolution. And also there is a straight portion. After the initial bendings, it becomes straight. So the bent portion is called the convoluted portion or pars convoluta, and the straight segment which continues as the loop of Henle is called the pars recta, straight portion of the segment. Okay. When you examine it in more detail, it is not just the two things, the curved and the straight portion. It has also got the proximal portion of the convoluted portion. There is the convoluted portion itself is divided into proximal and distal convoluted portions, and then there is a proximal pars recta and distal pars recta. So the bent and the straight portions are divided into proximal distals, and from this pars recta, tubular fluid enters the loop of Henle, consisting of an initial thin segment which conducts urine towards or into the medulla. So most of the nephrons, the loop of Henle will be in the medullary system, as I showed in the earlier picture, because the medullary interstitium is the one area which is important for withdrawing or absorbing the fluid from the tubular lumen. Okay, so for that, most of the loop of Henle and the collecting ducts all should be present in the medullary system, medullary part of the kidney, not in the cortical. Cortical area is only mainly for the filtration. So at the end of this ascending portion, the distal tubule begins, which comes into contact with both afferent and efferent arterioles connected to the glomerulus. And these three structures, that is the afferent arteriole, efferent arteriole, and the different distal tubule, these three structures form the juxtaglomerular apparatus. And this juxtaglomerular apparatus, as I told you earlier, is important for regulating the afferent arterial blood flow, or glomerular blood flow is regulated by this. Whenever there is a drop in volume, drop in sodium, drop in pressure, all these things will stimulate this to release renin from the endothelium of the afferent arterioles, which will go into, and all the things which just now saw. So this is responsible for regulation of renal blood flow and also involved in the control of systemic arterial blood pressure, because the angiotensin, which is finally angiotensin 2, which is the final product, is not only regulating the renal blood flow, it has effect on the other systemic arterial vasculature also. So it is another important role is to maintain our entire body blood pressure. So this picture shows you, this is the afferent arteriole coming here, controlled by the nervous system. Then it divides into the, and you can see the juxtaglomerular cells are present in the afferent arterioles. Okay, and these cells only release the renin. This is the macula densa cells in the distal convoluted tubule. This is only the sensing unit, and this is the efferent arterial flow. Now, if you see this picture, as I told you, the three components of juxtaglomerular apparatus, one is afferent arteriole, the other is macula densa in the distal convoluted tubule, the third is efferent arterioles. Now we know that this is the sensing unit. Afferent arteriole receives the blood. If the blood flow decreases or the pressure drops, then the signal goes to the macula densa. Macula densa makes the afferent arterioles release the renin, which has got to go into that. What is the role of efferent arterioles here?
Here, increase in the efferent arterial resistance.
Excellent, excellent. So this is the one which is like an outgate. So it will alter its lumen size to regulate the flow. So this is ingate. So let us say you have to have 100 people coming through the ingate, but only 50 are coming. Then what will it do? The macula densa senses that, asks the people to release the renin and allow more people to come. At the same time, blood has already come here. What the efferent arterial will do, it will allow only 50 people to go and not 100 people to go out, so that it will offer some counter resistance so that the filtration pressure will be maintained. Okay, So that is why nature has beautifully formed this arrangement where afferent arteriole, macula densa and efferent arteriole, all the three are involved in the regulation of blood flow. You are able to understand? And this is how the loop of Henle's are situated. So you have the nephrons divided into two sections. One is called the cortical nephron, which is mainly present in the cortex, but the loop of Henle will definitely go into the medullary system, medullary portion of the kidney. Whereas the juxtaglomerular, they have longer nephrons and they dip deep down into the medulla. And even though both of them are involved in regulation, it is the juxtaglomerular nephrons which are more responsible for the concentration of the urine and reabsorption of the filtered fluid back into the body. So what is the role of urea in the kidney? Urea cycle in the kidney and its importance. Does urea have a role in any?
Yes, sir, for
function of the-
concentrating the urine, urea cycle is important, sir.
Very good, very good, very good. Even though urea is a waste product or the product to be excreted, how is urea formed? What
From
is the
Ammonia,
Ammonia, from the
Ammonia
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 metabolism.
components, sir.
It is a protein metabolism end product. Is it correct?
Yes, sir.
Yes,
Yeah,
sir.
proteins are made up of amino acids. Amino acids are broken down and then ammonia is formed and the ammonia is converted to urea because ammonia cannot come out as it is own. So it is made into a water soluble component called urea. And so urea is actually a waste product, but urea is also important for, as you said, concentrating the urine. How it is done, we'll see. Urea is freely filtered at the glomerulus, but passively reabsorbed in the proximal tubule and collecting ducts. So it is getting reabsorbed both at the proximal tubule and also in the last portion of the nephron called the collecting ducts. Okay. The rate of absorption is facilitated when urine flow down the tubules is low and vice versa. So if you have a very slow flow and a small volume, more urea will be reabsorbed. If you have a very fast and very good flow, large volume, it will travel faster and it will go out in the urine. So when will you have your urea elevated? In the slow flow or fast flow? When
Slow
your
flow.
blood
Fast
urea
flow.
level.
Slow flows.
Slow flow.
Fast flow.
See, fast flow, it will go in the urine. It will not have time to get reabsorbed. Whereas when you have a low flow, more time is there, the fluid travels very slowly, so more of urea will be reabsorbed from the proximal as well as the distal collecting ducts,
Collecting.
and your blood urea level will go high up. So when your blood urea level goes high up, what is the condition you call that as?
Uremic encephalopathy.
Uremic or pre-renal azotemia, isn't it? So it indicates normal
Hypo.
volume or low volume in the blood.
Hypo.
It is a oligemia or oligouric state. Okay, this is explained. So the renal reabsorption is facilitated. That means it is encouraged when the urine flow down the tubule is low. But when the flow is very fast and volume is more, you will have less urea. Okay, so it's an indirect indicator of your volume status of the body. Okay, so that is how the urea becomes important, number one. Second thing is urea may be actively secreted also. So it is one thing is first it has to be reabsorbed. The second thing is it may be sometimes actively secreted by the pars recta of the proximal tubule. That is the straight portion of the proximal tubule, but the quantitative significance is not very clear. And there is a high concentration of urea in the medullary interstitium. This portion, what I told you is this is the medullary interstitium. So the urea that is reabsorbed is getting collected here, and this plays an important osmotic role in the concentration of urine by countercurrent process. Okay, So the urea cycle is nothing but the urea which is filtered freely at the glomerulus gets immediately reabsorbed at the proximal tubule, and whatever slightly remaining is also removed from the collecting ducts. This reabsorption depends on the volume and the rate of flow. And once the urea is reabsorbed, it is stored in the medullary interstitium to give the increased osmolality to the interstitium so that more water can be drawn out to make the urine more concentrated. So this urea plays a very important role in the concentration of our urine by countercurrent process. So this is a very valuable concept that you have to remember. Describe the intrarenal branches of renal artery. Of course, we have seen that, but to make it more easier, the renal artery first divides into, as I said, will be an anterior and posterior, and it goes.
Segmental arteries, interlobar.
Yes, so this goes into interlobar, and see this turn that is happening is the arcuate artery. Okay, you can see the name given here, the interlobar, which comes here and then goes on the side of the pyramid, turns acutely like this. This is the arcuate branch. So any obstruction or spasm usually occurs at the arcuate artery level. Okay, so if you do an ultrasound, when there is a chronic kidney disease, what happens? Blood flow will be normal up to this, but as it comes here, because the size is smaller and also it takes an acute turn, blood flow will be lost here. So normally the cortex receives more blood than the medulla. Almost 75% of the blood supply goes to the cortex, only 25 to 30% goes to the medulla. So when they do an ultrasound to see whether the kidneys are normal or they have gone into any CKD problem, this blood supply, which should be normally present in this huge amount in cortex, will not be happening because the arcuate arteries will get blocked and blood flow will not happen. So if the blood flow is normal, you will have a more dense shadow in the ultrasound picture and a lighter shadow in the medullary region, which is called the corticomedullary differentiation. And when the blood flow to the cortex is lost in CKD patients, this differentiation will be lost, and that will be the first indication in the ultrasound picture, which will be useful to detect CKD presence. That is why they immediately ask for abdominal ultrasound for the kidneys to see whether this corticomedullary dissociation or differentiation in blood supply is maintained or not. Another important point is the ureteric branch. You can see here, where does it arise from? It arises from the renal artery itself. This is the ureteric branch of the renal artery. So when the transplant is being done, if the surgeon is not careful, he can knock off this branch. Then what will happen? The ureter will become ischemic. Once it becomes ischemic, it will necrose and the ureteric leak at the junction of the kidney will happen. So the ureter may dehisce or it may start leaking, and even when the kidneys are working well and urine is formed, you will have a urine leak around the kidney. Okay, so this branch should be preserved. So the surgeon should stay away from going very close to the hilum, because the branch comes from the, as the artery enters the hilum, this is the area where it goes. Now the venous system. How does the venous drainage occur? Just like two renal arteries and their internal branches, renal veins. So
Renal
there are two renal veins drain the kidney, left and right, and they leave the hilum anterior to the renal arteries and empty directly into the IVC. Just like the arteries taking off from the aorta, the renal veins directly join the IVC. What is the importance of this knowledge about the renal veins directly going into the inferior vena cava? Any idea? Supposing the patient has a huge renal cell carcinoma, can they reduce the size of the tumor? if it is too inoperable.
Yes, sir.
How do they do that? They do what is called embolization. Okay, they can embolize the renal artery and vein and reduce the blood supply before attempting surgery and reduce the size of the kidney. Okay, so for that we know, and sometimes RCCs will infiltrate into the renal vein and enter into the inferior vena cava. Some portion of the tumor cells will occupy the inferior vena cava. Unless you identify that when you do a nephrectomy for renal cell carcinoma, sometimes the renal cell metastasis which has already entered that, you have to remove part of the inferior vena cava also. Otherwise it will go into the system and produce metastasis elsewhere. Okay, so for this reason we should know about the venous drainage also. And another reason is vena cava lies slightly to the right because the left renal vein is longer, because it has to cross over the aorta and come to the IVC, because IVC is more medial and the artery aorta is a little lateral or in the midline. And the right renal artery lies also posterior to the IVC. So this is the anatomical knowledge which is important more for surgeons. Now, what is Brodell's line and its importance? It's something called Brodell's line, and it has got.
It is the area between the branches of anterior and posterior renal artery.
Very good, excellent. And it's an imaginary line along the lateral and slightly posterior border of the kidney, which delineates the segments of the kidney supplied by the anterior and posterior divisions. So why should we know it? What is its importance? Your definition, your explanation for Brodell's line is correct. It is an imaginary line along the lateral and slightly posterior border of the kidney, which separates or gives an identification between the areas supplied by the anterior and posterior divisions of the renal artery. Where is it useful, this knowledge?
Approaching kidney in this area will decrease the blood loss.
Excellent, very good. It is an avascular plane of the kidney and is important access route for open or endoscopic. Nowadays, all of you must be aware that the donor nephrectomy is done
Robotic
by
surgery.
endoscopic procedure also. So for that, the surgical access will be with minimal bleeding. We can do that by knowing this. And what is unique about renal artery branches? Do they have anything special? Do they have intercommunications?
Yes, sir.
Yes, sir.
Yes, sir. Are anatomical end arteries. There is no communication between vessels. Okay. Trauma or obstruction in one arterial branch will eventually lead to ischemia and necrosis of the renal parenchyma supplied by this vessel. This is a very, very important knowledge. So most of the branches are end arteries. They don't communicate with each other because it is mainly ending up as a filtration system. Okay, and then becomes a capillary. So it is almost like an end artery. So this is the picture to know the 5 segments: the apical, upper, middle, and lower, and posterior. These are the 5 segments as I told earlier. And this is Brodell's line, which separates or which gives a imaginary line between the two, say, anterior and posterior, which will be the very least vascular area. Okay, so you can see the blood vessel coming here and then branching into all these things. So these are the 3 views of the kidney. So the Brodell's line has an importance to open as well as, and when you want to do a partial nephrectomy for any tumor or anything, it is better to go through this Brodell's line rather than cutting it wherever you want. And the 5 segments you have to remember, just like the lung segments: apical, upper, middle, lower, posterior. Okay, these are the things that you have to remember. What is the clinical relevance of arterial supply of the kidneys? Anyway, sometimes there are more than one renal artery supplying the kidneys. Have you ever seen that? Some of you have had exposure to transplant. The donor kidneys may have more than one renal arteries. Why is that? Normally, one kidney should be supplied by one renal artery only. But sometimes you find they have 2 or even 3 renal artery supply. Where do they come from? Do they all come from aorta, or can they come from any other vessel? Okay. This is because embryologically the site of formation of kidney is the pelvis. So during organogenesis, the kidneys are first formed in the pelvis. Then they ascend up, just like your thyroid forming in the tongue base and then descending down to the front of the neck. The kidney is formed in the pelvis and then it ascends up to the retroperitoneal area and the abdomen. And then during this migration, it may receive blood vessels from the iliac arteries or lower part of the aorta. Okay. So if you see in this picture, this is the main renal artery which is coming here. Sometimes the aorta itself will give another branch, second branch to the kidney. This is called the supernumerary or accessory artery. And there may be another branch coming lower from the lower down aorta, which is called the aberrant artery. Why this is called accessory or supernumerary artery and why this is called aberrant artery? By looking at the picture, can you tell me the difference? Just watch this area and this area.
It is not entering the kidney through hilum, sir.
Excellent. So the main artery and accessory arteries always enter through the hilum, whereas aberrant arteries will be away from the hilum. Separately, they will enter the kidney. Sometimes, if these 3 arrangements are present, you may, if this aberrant artery is a very small one, you can sacrifice this when you take the donor kidney. Okay, whenever there is a donation is being done, and there are all the 3 branches available. Main renal artery is there, accessory renal artery which is entering, both entering through the hilum, and there is a third aberrant artery. If the third aberrant artery is a very small artery, then you can sacrifice this and take only these 2 vessels. Okay, so that is the importance of the blood supply to the kidney. So during transplant surgery, if the donor kidney has more than one artery supplying that kidney, it may require multiple anastomosis. When there are 2 branches straight away going into the hilum, you cannot sacrifice this one. You have to anastomose this also to the recipient vessel. So the branches being end arteries, the additional arteries cannot be sacrificed all the time. Blood supply to the ureter is given by the renal artery. So if proper dissection is not done, as I told earlier, you may cause ischemia to the ureter and cause leakage of urine. The renal veins, these are all the clinical relevance of the arterial and venous supply or blood supply to the kidney. I should have made it blood supply, not arterial supply. So the renal veins have a thin wall and can be easily damaged during dissection or anastomosis unless sufficient care is taken by the surgeon. And during renal transplant, after harvesting, the donor kidney is flushed out of all the blood by perfusion fluid, cold perfusion or preservative fluid. So, and that is introduced through which vessel? Artery or vein? When you want to flush out the blood from the donor kidney before transplant, how do you inject or how do you perfuse the kidney? Through the artery or through the vein?
Through the veins.
The veins, sir.
Vein.
Vein is a reverse flow. In vein only it has to drain. So you have to introduce it only through the artery. So then only it will go through the entire flush and then come. You cannot go in the reverse direction. Okay. Next time when you happen to go and see, go to the nephrologist or perfusionist and see how do they do it. They will insert the cannula only into the artery, renal artery, and then flush it, and the whole perfusate fluid will come out. Initially, it will be fully blooded, then it will become clear as you inject. So this fluid is run into the renal artery by an infusion set and drainage occurs through the renal vein. So this is done till all the blood is washed out, as seen by a clear return of the infused fluid. It should not be having any blood at all. So avoiding excess pressure is important to prevent damage intrarenal. Sometimes I have had one experience where the new perfusionist, nephrology PG, because he could not flush properly, he used a pressure pump and then injected the perfusionate fluid, and the renal artery got torn at the hilum level, and inside also the vessels got damaged. Without knowing that, they did the anastomosis, and there was a lot of bleeding, and the kidney did not work. Okay, so it is very, very important to see that you do it at the correct pressure. Now, what are the types of nephrons? Already we have shown in a picture there. So how do you classify the types of nephrons?
Cortical nephrons and
Cortical and
juxtamedullary.
juxtamedullary. Excellent. There are two types, cortical and juxtaglomerular or juxtamedullary. And this is the picture of those two things. So they have all these things which already we have seen. Now coming to the next common question asked in the theory papers, describe the physiology of urine formation. This is a very frequently repeated theory question in the paper. So we should have some idea about how urine is formed in the body.
Usually
Yes.
3 interactions: glomerular
Hmm.
filtration,
Hmm.
tubular reabsorption, and tubular secretion.
Secretion, very good. Excellent. So
When
these
it comes
things
to
actually
glomerular
filtration.
when it comes to glomerular filtration, there comes Starling forces to regulate the fluid flux across the filtration barrier. And
Very good.
we also have this pressure difference, hydrostatic pressure difference from
Yeah.
our capillary system and the
Very
renal
good.
system.
Very good.
That
Okay. What are all the structures or constituents of the blood which are filtered by the glomerulus? It is the first filtration is the first step, isn't it? So, how much? As I already told you, 180 liters of plasma is filtered. Okay, so there is no RBCs, no proteins which are coming into the filtrate, into the Bowman's capsule. Why? How is it prevented?
the barrier pore
Size
size
of
and
the
their
of the protein
charges.
see because of the negative pressure charge over the basement membranes and the food process.
Food processes. Okay, so the tight junctions, the negative pressure, negative charge, and the thickness of the basement membrane regulate the control. So only fluids and substances which have low molecular weight, they will be allowed to pass through, because our albumin has got a molecular weight of more than how many Daltons?
80 kilos.
80,000.
More than 40,000 kilodaltons. Okay, so structures which are so big will not be allowed. But if you get proteins in your urine, what does it indicate? Which part of the filtering system is at fault? Is it the capillary
Basement
endothelium
membrane.
or the basement membrane or the food process?
Basement membrane.
Both the
It
food
is the
process.
basement. So in no, it is the basement membrane which gets damaged. That is the one which repels the proteins. So in chronic kidney disease or diabetic nephropathy, it is the basement membrane which gets affected, and that starts allowing the protein to come in. That is why the earliest indicator of renal nephropathy, diabetic renal nephropathy is microalbuminuria. More than 300 milligrams per 24 hours of urine. If albumin is present in the urine, then we suspect diabetic nephropathy as set in. Okay, so this picture will tell you all these things, how the filtration is taking place, proximal tubular reabsorption, loop of Henle, distal reabsorption, collecting ducts, and urine formation. Very simple diagram so that you can easily draw it in the exam. At the Bowman's capsule level, 180 liters of fluid is filtered. Molecular weight more than 70,000 or greater cannot be filtered. Particular weight 5,000 and less will be easily filtered as water. And the filters of what are the things that are filtered are water, glucose, electrolytes, amino acids, urea, and creatinine. All these things will be allowed to pass through. And once they pass through, it comes into the proximal tubule. And 65% of sodium and water are reabsorbed here. And all glucose, potassium, urate are also reabsorbed. Bicarbonate is also reabsorbed, but hydrogen ions are secreted into the tubular fluid and rejects urea unneeded. Excess of urea also will be allowed to pass through. And once it comes to loop of Henle, there is the area of profound concentration. Sodium transport is the main thing that is happening in the loop of Henle from the preceding limb. Sodium and water do not form as a team, and countercurrent establishes hypertonic interstitium. So the reason why countercurrent mechanism happens is exchange happens is to maintain a hypertonic interstitium. As I told you, this area, this is the thin loop of Henle, this is the thick loop of Henle ascending. So this portion is the interstitium. So the countercurrent mechanism keeps this interstitium in a hypertonic state. So the urine will be isotonic in the or the filtrate fluid. We cannot call it as urine at this stage. The filtrate fluid will be isotonic in the proximal tubule. Then it becomes, as it enters the loop of Henle, it is isotonic, then becomes hypertonic, and at the end, when it goes out through the ascending thick limb into the proximal distal convoluted tubule, it becomes hypotonic. So all the three things will be there in the loop of Henle. Initially isotonic, then as the water is reabsorbed in the descending thin limb, it becomes hypertonic because more of solutes are there in the filtrate fluid. Then in the ascending limb, all the solutes are removed, so it becomes again very watery and becomes hypotonic. And in the distal convoluted tubule, water, what is coming out as a hypotonic fluid, it is again reabsorbed with the help of ADH. Some sodium is also reabsorbed, but potassium, hydrogen, and urate are secreted back into that. Ammonia is also secreted and keep the cations and the anions in balance. And initially the fluid will be hypotonic, then it will become isotonic. In the collecting disc, this is the last chance for water absorption. Beyond that, water absorption cannot take place. And again, it is by the ADH help, and it becomes initially hypotonic, then hypertonic, depending upon the requirement of water reabsorption. And finally, when it comes out of the body as urine, the specific gravity is between 1010 to 1025. You can take this decimal point off, then remember it as 1010 to 1025. It is always slightly acidic, 4.6 to 4.8, and it should be negative for glucose because it is all absorbed in the proximal tubule itself, and it should not have any ketones, it should not have any blood, it should not have protein, it should not have bilirubin, it should not have too many bacteria, it should not have any CAS or epithelial cells. So this should be the characteristic of the normal healthy urine. And the pressures which are doing that are in the glomerulus capillaries, the hydrostatic pressure is 6 millimeter, osmotic pressure is 25 into 5, more permeable other than the capillaries. Then in the this is the efferent arterial level. It is the hydrostatic pressure which is lower and osmotic pressure is higher, and when it comes as a capillary, again you can see the osmotic pressure is higher. And then the vasa recta, again the hydrostatic pressure is low, sluggish blood flow is there. Then in the peritubular capillaries, the hydrostatic pressure is again low and osmotic pressure is high. And veins, hydrostatic pressure is low and osmotic pressure is high. And the products which are reabsorbed are urea, creatinine, uric acid, sulfates, ammonia, drugs, and excessive vitamins. All these things will be reabsorbed. So even if you don't remember this portion of the picture, if you remember this upper half of the picture, you will be able to write a decent answer on the formation of urine. So as I think Risha answered that question, it can be divided into filtration, reabsorption, and concentration, and finally how the urine is formed. Okay, so this is how you have to write the answer for the physiology of urine formation. So you can remember all these numbers: 180 liters of plasma filtered, and ultimately you will get only about 1 to 1.5 liters of, or a maximum 2 liters of urine per day. Now the next thing we have to know is renal hormones and actions. Sometimes they ask this as non filtration function of the kidneys. So what are the renal hormones that are secreted and what are their actions? Can you name a few renal hormones or hormones?
Renin and angiotensinogen.
Renin,
Erythropoietin.
angiotensin, aldosterone is the major thing. Okay, renin, you don't directly get it into this thing, but ultimately it results in aldosterone stimulation or secretion, angiotensin formation. Is ADH a hormone, antidiuretic hormone?
It is from the
Name.
PT.
Yeah, it is also a hormone. The name itself says antidiuretic hormone.
Yes,
So
sir.
we have
Also,
aldosterone, we have ADH, we have angiotensin. Then what else is the hormone?
calcium,
Erythropoietin.
vitamin D, calcium.
Erythropoietin,
Vitamin D and endothelins.
endothelin, not endothelin. We have atrial natriuretic peptide.
Natriuretic
We also-
peptides.
So first thing we have to know is something about is aldosterone. What is aldosterone and where does it act?
In the
Acts in the
collecting that
Usually it is
tubule.
First, what is aldosterone?
It's a mineralocorticoid.
mineralocorticoid.
Corticoid secreted by the
zona
part of the-
glomerulosa,
ah,
adrenal
so it's a
cortex.
chief mineralocorticoid produced by the adrenal cortex, acts at the distal segment of the nephron, causing reabsorption of sodium and water. Okay, so this is a chief mineralocorticoid produced by the adrenal cortex, and it acts on the distal segment of the nephron. That is the collecting distal convoluted tubule and collecting duct. That is the distal portion. What factors regulate the release of aldosterone?
Hyperkalemia,
Low sodium.
hyponatremia, hyperkalemia.
Hyperkalemia. Which is more powerful?
Hyperkalemia. sir.
Hyponatremia, sir.
Natremia.
Hyperkalemia.
Hyperkalemia. Yes. Factors regulating
Hyponatremia.
aldosterone are potassium concentration in the extracellular fluid. That is, if the potassium level is high, it will immediately stimulate aldosterone release. Then the renin-angiotensin system is the second important thing which stimulates the aldosterone, and sodium concentration in the extracellular fluid. These are the three factors which are responsible, but among this, the potassium is stronger trigger, followed by renin and then sodium. So that is the order. Potassium level is the most strongest trigger for release of aldosterone. Second will be the renin release. Third will be sodium level. What is ADH? Where does it act and how is its release controlled?
Antidiuretic hormone released by posterior pituitary.
Very good. Posterior pituitary directly, or is it found elsewhere and then brought to posterior pituitary?
It is formed in the hypothalamus and stored in the posterior part of pituitary, sir.
Is it called hypothalamus or something else?
Supraventricular.
Supraoptic.
Oxytocin. Supraoptic.
So it's a hypothalamus released from the neurohypophysis. Okay, neurohypophysis which acts on the distal nephron. Okay, and the distal tubule and collecting ducts are almost totally impermeable to water in the absence of antidiuretic hormone. So water is not reabsorbed and it will be lost in the urine. So the presence of ADH, tubular permeability, is increased by insertion of what are called aquaporins in the luminal surface of the tubular cells, and water will get reabsorbed. So only if ADH is present, it will insert something like a tube into the luminal surface of the tubular cells so that water can enter. Otherwise, water cannot pass through the distal collecting tubules. So the release of ADH, how is it controlled? It is controlled by the osmotic concentration of the extracellular fluids. That is, if you don't drink too much of water and become dehydrated, will it suppress ADH or increase ADH secretion?
Suppresses ADH.
If you suppress ADH, what will happen?
Rises
Antidiuretic effect.
Rises intravascular volume, sir.
So whenever the osmolality increases, ADH release will be enhanced, so that, I mean, suppressed, so that you don't get, I mean, you want more water to enter the body. So more ADH will be released when you are dehydrated. On the contrary, if you are drinking too much of water and you are having excess load, then more ADH will be, ADH release will be suppressed, so that more urine will be formed. Okay. So dehydration, more ADH, overhydration, less ADH. Okay, remember that way. So osmoreceptors located near the hypothalamus sense the extracellular fluid concentration and release ADH accordingly. So ADH is also inhibited by stretch receptors of the atrial atrium, baroreceptors. Okay, depending, because the baroreceptors sense the volume in the heart. So once the volume is high, more ADH will be released. Volume is low, less ADH will be released. I mean, when the volume is low, more ADH will be released, and less volume, more ADH will be, I'm sorry, the release will be suppressed. Now, what is angiotensin? How is it released? This is the third hormone. What we have seen already are, one is aldosterone, the second is ADH, the third is angiotensin. How is it released and what are its actions?
It is released by the conversion
the
of
liver.
tensinogen to angiotensin.
All this we have already seen. Angiotensin is a hormone that has direct renal effect as well as general systemic effect. So renin has to first convert the angiotensinogen in the liver to angiotensin 1. Angiotensin 1 has to go to the lung to become angiotensin 2, and that angiotensin will be the main acting angiotensin hormone. So renin is a small protein enzyme released by the kidneys. Stimuli for the release of renin include beta adrenergic stimulation, decreased perfusion of the afferent arterioles, and reduction in sodium delivery to the distal convoluted tubule. All these things will stimulate the production of renin from the endothelium of the afferent arterioles. Once released, renin acts on hepatic angiotensinogen to form angiotensin 1. Angiotensin 1 is then converted by ACE in the lung to form angiotensin 2. In addition to causing powerful vasoconstriction, angiotensin 2 stimulates the release of aldosterone from adrenal cortex. So the two actions of angiotensin are, one, to cause generalized vasoconstriction as well as increase in the afferent arterial flow in the glomerulus, and release aldosterone so that more sodium and water can be reabsorbed from the kidney. And aldosterone increases salt and water retention by the kidneys once it is stimulated. So both this vasoconstriction caused by the angiotensin as well as the absorption of salt and water increase the arterial pressure. So that is how body tries to maintain the normal blood pressure. So this is the picture description. So the precursor for renin is alpha-2 globulin. So from that only you get renin formation, which goes to stimulate angiotensin 1, which gets converted to angiotensin 2, which stimulates adrenal to form the aldosterone. And the other actions are hypothalamus producing osmoreceptors, that is neurogenic stimuli coming to posterior pituitary, ADH release, ADH causing water reabsorption. And this macula densa causes the release of renin. So all these things are shown in one picture. So the macula densa is nothing but a collection of group of specialized cells in the distal convoluted tubule, which is very close to the afferent arteriole and efferent arteriole. So all the three put together is called the juxtaglomerular apparatus. Okay. What is ANF? Atrial natriuretic factor. This is the fourth hormone which acts on the kidney. So this is a peptide hormone synthesized, stored and secreted by the atrium of the heart, cardiac atria. So it is prepared there. What causes this release? When will it be released?
Heart failure.
Stretching of atrium
Heart
in case
failure.
of increase in the volume of blood.
So the stimulus is atrial distension, stretch or pressure. Okay, all these three things. Atria can get distended, they can get stretched too much, or there may be an increase in the pressure. All these things will cause release of atrial natriuretic factor. What is its action on the kidney? What does it do? Even though it is produced in the heart, in what way it is helpful to maintain the heart function?
They promote
It
increase in the
decreases the
GFR and
sodium and
filtration
water
fraction.
It causes natriuresis. It excretes
Very
more
good.
sodium.
Name itself is telling atrial natriuretic factor or peptide. So natriuresis means allowing more sodium containing
to enter
urine
the
to pass
urine.
through. Okay, so it improves these. Whenever you allow sodium to go out, water also will go out. So the volume load on the body will come down. So if the heart is struggling to pump the volume, it will be reduced so that the preload will be optimal instead of overloading the heart. Okay, that is the main idea. Antagonizes both the release and the end organ effects of renin, aldosterone, and ADH. ANF is one of the most potent diuretics known, and inhibition of plasma renin, angiotensin, aldosterone produces a dose-dependent decrease in blood pressure. So ANF is likely to cause a dose-dependent blood pressure also. What is the role of vitamin D in kidney function?
It increases calcium absorption and excretes phosphorus.
It is important for calcium regulation. You can say that in one sentence, that it is important for calcium regulation. So along with parathyroid hormone and calcitonin, it has a vital role in calcium metabolism. Okay, and it is called cholecalciferol. The name of vitamin D is cholecalciferol. The sources by which we can get them is from the diet as well as from the ultraviolet radiation of cholesterol in the skin. So skin and diet are the two important sources for us to get the cholecalciferol or vitamin D. Nowadays, vitamin D has been identified as a very important vitamin, and if you go to any physician, they write about assessment of your body vitamin D content and B12, and 99% of the labs, they give a report saying that your vitamin D level is insufficient or below the satisfactory level, despite the fact that we have so much of sunlight in our country, in our areas, and we get ourselves exposed to ultraviolet so much. But despite that, they have all the labs invariably give a report saying that your vitamin D levels are quite low. And to become active, this cholecalciferol is not a drug, hormone which can directly act. So it has to be activated first at the kidney level by adding one hydroxyl group at the 25th position of its carbon nucleus. Then it goes to the liver, where another hydroxyl group is added in the first position. So these two, the 25th position and then the first position, make it called as a dihydroxycholecalciferol. So at the kidney, it becomes a monohydroxycholecalciferol. At the liver, it becomes dihydroxycholecalciferol. So the hydroxyl group is added at these two positions. And in patients who are having advanced renal disease, they have abnormal calcium levels also. That is why you may find that all CKD patients will be receiving some calcium supplementations, because the conversion into the 25 hydroxycholecalciferol does not take place properly. So once the first addition of hydroxy unit is not added, it cannot get converted to dihydroxycholecalciferol. And this is very important for absorption of calcium. So by giving more calcium in the diet, you make at least some required level get absorbed, even though the normal absorption will not take place. So you have to supplement and give more calcium in the diet, so that the required amount will be somehow absorbed. Otherwise, patient will go in for severe osteoporosis very soon. So that is the main important clinical relevance of this. Now, what is the function of prostaglandins on the kidney? This is the last hormone we have to know about.
Vasodilation.
Vasodilatation. Vasoconstriction is not there.
F2 alpha.
Thromboxane, it's also a prostaglandin group only. Okay, both are produced from the cell membrane, the conversion of arachidonic acid into both prostaglandin and thromboxane all belong to the same group, but with opposite effects. So prostaglandin PGE2 and thromboxane A2 modulate the renal effects of other hormones. Prostaglandin is a vasodilator, whereas thromboxane A2 is a vasoconstrictor, because it contracts the vascular smooth muscle. And the renal prostaglandin influence renal excretion by helping the medullary flow. So as I told you earlier, majority of the blood flow, almost 80% of the renal blood flow goes to the cortex for filtering function, and only about 20% comes to the medulla. And that medullary blood flow is regulated mainly by the renal prostaglandin. So when you treat a patient and give them with NSAIDs, non-steroidal anti-inflammatory drugs, how do they affect the kidney function? This is a very common question asked in the examination. What are all the conditions, or why NSAIDs are contraindicated in patients with kidney disease? What happens exactly by giving NSAIDs? How can it damage or affect the kidney function?
They inhibit the arachidonic acid, in turn inhibit prostaglandin secretion. So there will be decreased blood flow to the medulla.
So medullary ischemia will be caused, and another complication that can be produced is it will call medullary interstitious nephritis. Okay, the interstitium, as I told you earlier, which is responsible for concentration, that will also get inflamed. So it will produce medullary interstitial nephritis as well as reduce the flow. And that is how the things that the NSAIDs affect the renal function. How do they affect the gastric function? Why NSAIDs are more irritant to the gastric mucosa compared to paracetamol and other analgesic drugs?
It's a mucosal blood flow.
Because it's gastric
mucosal
erosion.
blood flow or something else?
Because
Does it
it's
cause
gastric erosion.
Decreases secretions mucin.
Mucin, which is a slimy coating to protect this thing. So the mucin secretion in the stomach is also dependent on prostaglandin. So when they are blocked by the NSAIDs, the mucin secretion reduces, the covering slimy coat is not there, so the stomach's own acid will erode and cause ulceration. Okay, that is how the drug is not directly causing that. It blocks the prostaglandin, which is very much needed for production of the mucin, which is a protective coat against the hydrochloric acid secreted in the stomach, and that will not be available. So the stomach's own hydrochloric acid will erode the stomach and produce gastric ulceration. So these are the two effects which you have to remember for NSAIDs. One is the kidney effect and another is the stomach effect, or the effect on the gastrointestinal system. Now the next function commonly asked is, how do kidneys help in regulation of acid-base balance? This is another common theory question asked in the examination. After the urine formation physiology, the next frequently asked question is the, how do kidneys help in the regulation of acid-base balance?
It reabsorbs bicarbonate and excretes H plus in the PCT and the collecting with the help of T cells and I cells.
Okay. Why should it reabsorb bicarbonate? Which is produced more in our body, hydrogen ions or bicarbonate ions?
Hydrogen ion, sir.
The carbon dioxide.
Hydrogen ion is produced more so that it excretes the hydrogen ion.
We have to always excrete the hydrogen ions. Which, if any of you had the chance to read an old textbook of Wiley, Churchill, and Davidson, anesthesia textbook by Wiley, the chapter on acid-base balance starts with the first sentence: life is an acidogenic process. That is, all the reactions that take place in the body, they produce more of hydrogen ions. So life is an acidogenic process. And that is the reason your blood pH, what is the normal blood pH?
7.35 to
7.35 to 7.45. So according to chemistry, is it alkaline or acidic?
Slightly
acidic.
It is in chemistry, 7 is neutral. Anything below 7 is acidic. Anything above 7 is alkaline. That is what we are taught in chemistry, isn't it?
Yes, sir.
So in our physiology, we have our blood slightly on the alkaline side, 7.35 to 7.45, even though we call it as normal range, and we call anything less than 7.35 acidic and anything more than 7.45 alkaline. According to chemistry, our blood is slightly alkaline, isn't it? That is because to counteract the hydrogen ions that are produced more than the bicarbonate ion. So the first function of our kidney is to remove the hydrogen ions as much as possible and reabsorb bicarbonate as much as possible to maintain the blood in a slightly alkaline state. Okay, that is the first and foremost thing. The kidney plays a pivotal role in managing acid-base balance by reabsorbing filtered bicarbonate and removing excess hydrogen ions. Which portions of the nephron secrete hydrogen ions? Is it done through the entire proximal convoluted tubule, tube of loop of Henle, distal convoluted
tubule and distal and collecting duct?
Distal collecting duct.
So epithelial cells of the proximal tubule, the thick portion of loop of Henle, distal tubules and collecting ducts, all these 4 areas. Epithelial cells of the proximal tubule, thick portion, ascending portion of the loop of Henle, distal tubular cells and collecting ducts. All these 4 areas, they secrete hydrogen into the tubular fluid. That is the fluid which is ultimately going to become urine. And that is why, as I told earlier, our urine is always slightly acidic, 4.6 to 4.8. In chemistry, that is acidic. So the main reason a normal urine is acidic because hydrogen ion is secreted into the tubular fluid. What reactions happen to cause this secretory process?
Carbon dioxide combines with water to form carbonic acid.
Very good, very good. And
with
then
the help of
carbonic acid is a strong acid or?
With the help of carbonic anhydrase, then it cleaves it into bicarbonate and H+.
Very good, excellent. The secretory process actually begins with carbon dioxide in the epithelial cells, where under the influence of carbonic anhydrase, it will combine with water to form carbonic acid, which is a very unstable acid. It will immediately, this carbonic acid will dissociate into bicarbonate and hydrogen ions, and hydrogen ions are actively secreted into the tubular fluid in exchange of sodium ions. So hydrogen ion and sodium ions are exchanged to maintain electrical balance between ions and cations and anions. What happens when you become alkalotic, slightly alkalotic? So this is the normal process to maintain acid-base balance. Supposing we become alkalotic, then how does the kidney help in correcting that to bring back our normal pH?
Sir, in the DCT, it will reabsorb the H plus and excretes potassium through
So
H plus potassium.
alkalosis, bicarbonate level will be high or low?
High.
High, sir.
So should you eliminate bicarbonate or should you take potassium?
Excretion of
Ah,
It
Increase
an
the H
increase
plus.
in bicarbonate in alkalosis means that filtered amount of bicarbonate exceeds the amount of hydrogen secreted. Okay, and because excess bicarbonate must react with hydrogen again with to form carbonic acid, and the reverse process. So carbon dioxide has to be formed to make it neutralize the excess bicarbonate. But instead of that, what the kidney does is it removes or loses the bicarbonate. Normally, it tries to retain or absorb bicarbonate as much as possible. But if you become alkalotic, you develop metabolic alkalosis, then the excess bicarb will be lost in the urine, but it will not go alone. It will take sodium also. The patient will become hyponatremic, bicarbonate also will be lost. So that is the mechanism. It will try to correct the alkalosis. In the same way, sodium and excess bicarbonate are removed in the extracellular fluid also. So that is how the alkalosis is corrected. Now, what will happen if a patient becomes acidotic? How does nature try to correct it? The opposite of this should happen, isn't it?
excretion
So
of H plus.
you have to excrete more of hydrogen ions. So in acidosis, the concentration of hydrogen ion increases to a level far greater than that of bicarb in the tubules, and excess hydrogen ions are lost in the urine through either combining it with phosphate or ammonia buffer system. Okay, what I am talking about is all in the normal health. It is not a pathological state. So day to day, sometimes we may become slightly alkalotic, we may become slightly acidotic, not in a pathological way. So whatever little changes are happening, these are all corrected by the kidney. This is the mechanism that is happening. So how do kidneys help regulation of acid-base balance in normal health? So all these answers are pertaining to a normal, healthy, functioning kidney. Okay, don't confuse it with a pathological state. So the small changes can happen in all of us, in healthy people also, but body immediately corrects to keep our pH within the normal range. If you become alkalotic, bicarb will be lost. If you become acidotic, hydrogen will be lost. So if you write this answer, that is the correct box you have to write for regulation of acid-base balance. So this is a pictorial description how it is happening, how these phosphate and ammonia help to remove that. And this is again another pictorial description. So cellular mechanism of proximal tubule, hydrogen and bicarbonate transport, and what percentage of bicarb reabsorbed at various level. So in normal healthy kidney, it always tries to reabsorb bicarbonate and eliminate hydrogen ion, because as I told you, life is an acidogenic process and more of hydrogen ions are produced in our body. So to maintain the slightly alkalotic pH, we need more bicarbonate. So bicarbonates are reabsorbed. Is there any percentage how much is reabsorbed in the various levels of the kidney?
Almost 90% in the proximal convoluted.
Proximal convoluted. Very good. Majority is there in the proximal convoluted tubule, and the rest, almost 80%, is in the proximal convoluted tubule, 10% in the thick upper limb, ascending limb of loop of Henle, 6% in the distal tubule, 4% in the collecting ducts. Okay, so 80, 10, 6, 4. So maximum is in the proximal tubule, 10%. These are the 4 locations I told you where bicarb is reabsorbed. So maximum is in the PCT, 10% in thick ascending limb, 6% in the, distal tubule, 4% in collecting ducts. Okay. Now, how is the renal net acid excretion calculated? So we saw that more hydrogen ions are being eliminated from the body to maintain the slightly alkalitic pH. So is there any way we can calculate how hydrogen ions are eliminated or net acid excretion is calculated? Sometimes this may be asked, and the formula for that is net acid excretion is equal to volume multiplied by U. Here the acronyms are V, volume of urine produced per unit time, multiplied by urine concentration of ammonia plus urine concentration of titratable acid, that is phosphoric acid and sulfuric acid, minus urine concentration of bicarbonate. So these are the hydrogen ion containing substances. As I told you, hydrogen ion is eliminated, buffered with ammonia or phosphate. So if you measure these two, it will give a rough idea about the hydrogen ion content. And from that, if you remove the bicarbonate content in the urine, you will be able to get what is the net acid elimination, because always hydrogen ion excretion will be more than bicarbonate ion. Okay, if you remember that basic simple point and multiply with the urine volume, you will be able to find out the net acid excretion. Now there is a condition, pathological condition called renal tubular acidosis. And if that happens, what are the characteristics of it? What exactly is renal tubular acidosis and what is its characteristic? And why it is important for us as anesthesiologists? So this is a condition which tubular secretion of hydrogen and reabsorption of bicarbonate are impaired, despite the fact that GFR is normal. Whereas in patients with chronic kidney disease, CKD, GFR is the one which gets affected. So we always assess the severity of CKD by GFR, isn't it? Normal grade 1 is 90 to 120 is normal. Anything less than 90 is grade 1, 60 to 90 grade 2, 30 to 60 grade 3. Like that, we keep on grading the severity of CKD by GFR. But in renal tubular acidosis, there is a normal glomerular function, but the tubular function of eliminating the hydrogen ion and reabsorbing the bicarb is affected. That is the condition called renal tubular acidosis. And it was termed renal acidosis, which also called as tubular insufficiency with insufficiency with glomerular sufficiency. So without glomerular insufficiency, that means the glomerular filtration and flow is normal, but tubular function is affected. So this literally is characterized by normal anion gap metabolic acidosis with an alkaline urinary pH. So in renal tubular acidosis, instead of having an acidic urine, the patient will have an alkaline urine because bicarbonate reabsorption is affected. But his hydrogen ion concentration will increase because that is not secreted and eliminated properly. So because of that disturbed tubular function, patient goes into an acidotic state with an alkaline urine and a preserved glomerular filtration, flow. and that is the condition which causes renal tubular acidosis, which can ultimately end up as kidney failure and affect the cause morbidity also. So, what are the effects of anesthesia on normal kidney function? This is
decreases GFR.
All conditions, GA, regional, everything will affect, or what is the mechanism? So, general anesthesia is associated with a temporary depression of renal blood flow, GFR, urinary flow, and electrolyte excretion. Okay, this is very common in all patients. Even if you have a normal kidney function, general anesthesia will cause a temporary depression. That is, it will get reverted back. And why this depression happens?
Because of sympathetic blockade and vasodilation.
Because it will alter the renal blood flow by affecting the vascular system.
Perfusion.
And similar changes can occur after spinal and epidural anesthesia, but the magnitude of changes tends to parallel the degree of sympathetic block and blood pressure depression. So, general anesthesia also will cause some amount of myocardial depression, vasodilation, decrease in blood pressure, which is going to reduce GFR, that is glomerular filtration rate, and cause a temporary depression in all the functions of the kidney. Similarly, if your spinal and epidural, if your level of block is very high and it causes a sympathetic block, again the blood pressure will drop, and again the GFR will drop, and renal function will be temporarily affected. Once you restore the normal blood pressure and volume, then the function will come back. But the effect primarily will be a temporary depression, both by GA as well as by spinal and epidural anesthesia. This is number one. The second thing is, this is consistent and generalized depression renal function. What are the factors which cause this are? One is the type and duration of surgical procedure. The longer the procedure, there are possibilities that the vascular hemodynamic status interference will be more. Then the physical status of the patient, preoperatively, whether he is a ASA1, ASA2, ASA3 candidate, that is a very important factor to cause this depression. What was the volume status and electrolyte status of the patient at the time of undergoing anesthesia and surgery? What is the depth of anesthesia, and what are the drugs that you are going to use to produce anesthesia? All these 5 things: type and duration of surgery, physical status of the patient, volume and electrolyte status, depth of anesthesia, and choice of agent. All these 5 factors have a say in the depression of renal function. So, only proven direct toxic effect. So, this functional, temporary functional depression is indirectly secondary to the this vascular status, the hemodynamic status. Whereas some drugs like methoxyfluorine, which is not used nowadays, it has been banned, but for exam sake, you have to know, when it was introduced, a lot of people died of renal failure postoperatively, because the fluoride directly affected the nephron function and caused a renal failure. What type of renal failure was produced by this drug, methoxyfluorine? Was it an oligouric renal failure, or in renal failure, normally what happens? Urine production decreases or increases?
Decreases.
Decreases.
Oligo.
Whereas methoxyfluorine produced a polyuric renal failure. The concentrating ability of the distal convoluted tubule and the collecting ducts were totally affected by the fluoride that is present in that, and patient passed lot of urine like as though they are suffering from diabetes insipidus, and died of dehydration, which ultimately caused reduced GFR, and that is the mechanism. So, contrary to the normal oligouric renal failure, methoxyfluorine produced what is called polyuric renal failure, and that is the reason why it was completely banned and it is not available. But some examiners may be fond of asking that if you answer very well and you want to get higher grades. Then mechanical ventilation, which we do in our ICU, that also can affect the normal renal function and sodium excretion, and that depends on the increase in intrathoracic pressure, which will affect the ADH release and the unloading of baroreceptors, activation of renin-angiotensin system, all are involved when the patient is on mechanical ventilation. So earlier days when people started using ventilator, many patients died of renal shutdown and renal complications rather than lung complications. That is because these factors caused interference with the renal function, and that is how patient landed up with kidney injury. And renal ischemia and reperfusion injury is a leading cause of perioperative acute kidney injury, which is a complication of major vascular, cardiac, transplant, and liver surgeries. So, as I told you earlier about the renal cross-clamping and renal perfusion, whether it is in transplant or in vascular surgeries, all these things again can produce or land up in acute kidney injury by itself. And the drug propofol which we use has shown to have protective effects against ischemic renal reperfusion injury in multiple organs, including heart, kidneys, and liver and intestines. That is why we prefer propofol as a drug of choice for liver surgeries, transplant surgeries, and cardiac surgeries, because it has shown some protective effects in this. Now the recent advances, some of the markers are there, just like cardiac biomarkers. You have troponin for identifying acute coronary syndrome. Similarly, they have found some few markers to find the damage to various parts of nephrons. Can you name these biomarkers? Are you aware of any of them?
Cystatin.
Excellent, excellent, very good. So these are the areas. See, this is a markers of glomerular function are cystatin, kidney 3 like protein, hepcidin, proencaphalin. These four are markers to find out whether the glomerulus is affected. Okay. Then the markers of inflammation and repair are calprotectin and HGF. Markers of tubular damage, that is the proximal or distal or loop of Henle tubular damage, are alpha GST, NGT, so many things, alpha microglobulin, netrin, microRNA are all there. And for markers of cell stress, there are IGF. Even if you don't remember all these things, cystatin C and NAG assessment are now available as a investigation. So NAG you should remember as a marker of tubular damage. Cystatin you remember as marker of glomerular function. These two tests are now available, and that will be helping you to find out whether there is any acute kidney injury. These are more useful in detecting acute postoperative kidney injury. So how can the risk of AKI detected preoperatively, how biomarkers help in this respect or in this aspect? Is there any way we can, just like we make a assessment of a patient with cardiac disease coming for anesthesia, is there a preoperative way of detecting the acute kidney injury, whether the patient will have post-op acute kidney injury or not?
Elevated creatinine.
That is a general way of finding out whether the kidneys are functioning normally or not, isn't it? So if the patient has got elevated creatinine,
decreased urine
the
output,
kidney is damaged, that is a chronic state. But we are asking about acute kidney injury, possibility of. So further we must know whether the patient is having a normal GFR or not before surgery. Okay. If that is found out, then it will be measurement of renal functional reserve preoperatively was shown to identify patients at increased risk of acute kidney injury post-surgery. And that can be done by direct measurement of GFR rate at the bedside with the new techniques which are available and which can detect the acute kidney injury. The new biomarkers vary in their anatomical origin and physiological function and time of release after the onset of renal injury. and they can be divided into functional markers and damage biomarkers. Okay? So once you know this level of cystatin C is high in the blood, that means the glomerular function is already affected. If you find NAG is elevated, that means you know tubular function is affected. So you can test for this in the preoperative phase. So patients with biomarker positive but creatinine normal, they have what is called subclinical acute kidney injury, and they have a very poor prognosis. That means the biomarkers are released because the kidneys are already damaged. But because creatinine is normal, we tend to think that these patients are normal, and once they go in for a slight hypotension intraoperatively, their kidneys shut down immediately and they become dependent on renal replacement therapy and all those things. But we are fooled by the fact that creatinine was normal preoperatively. But if the patients who had no biomarkers, but their creatinine is elevated, they have a better prognosis because we know that their GFR is already decreased, and we take more precaution to prevent acute kidney injury in these patients. So this is the recent advancement that happens in the kidney, which I thought to share with you. Now the last part of the discussion today is we must know something about the diuretics because it is connected with the renal function. So what is a diuretic?
Increase the production of urine.
Excretion of water.
A class of medications that increase urine output by decreasing the reabsorption of water and sodium. Okay. What are the indications for their use?
Heart failure.
Systemic
pulmonary edema. Okay. Common conditions include hypertension, congestive heart failure, pulmonary edema, and cerebral edema. These are the 4 commonly indicated conditions. They are used to treat conditions of intravascular volume overload, particularly in patients refractory to fluid and salt restriction. Then, where do they act?
Collecting duct.
They act in the various parts of nephron, not only in the collecting ducts, from proximal tubule to loop of Henle, distal connector tubule, collecting duct. All these locations they can act. Okay. Diuretic target receptors on cell membranes within the renal tubules. And how are they classified?
Depending on the site they act.
Loop diuretics,
potassium thiazide
diuretics,
Thiazide diuretics.
Carbonic anhydrase inhibitors.
So they are categorized by their primary site of action in the nephron. Okay, it has to act on the nephron to regulate, increase the flow, increase urine formation. All these things has to be done by action on the nephron. So this is the classification. Loop diuretics is a commonly used one. Examples are furosemide and bumetamide. Their mechanism of action is they inhibit the sodium potassium 2 chloride importer. Where is this present? It is present in the thick ascending loop of Henle. That is why it is called loop diuretic, because it is acting on the thick ascending loop of Henle. And the indications are edematous disorders like heart failure, nephrotic syndrome, ascites, hypertension, and hypercalcemia. And the dose is 0.1 to 1 milligram per kg IV or 0.75 to 3 milligram oral. For furosemide, bumetanide is another loop diuretic. Dose is 0.5 to 3 milligram IV or 1 to 5 milligram oral. And the electrolyte abnormalities which can be caused, these are the side effects of the drug, is it can cause hypokalemia. So chronic administration of loop diuretics, you must always think of supplementing potassium to those patients. So you will have to think that they can go for hypokalemia, hypernatremia, hypocalcemia, or metabolic alkalosis. Rarely they can go for hyponatremia, hypokalemia, and hypomagnesemia if it is administered on a long-term basis. Then the second category is thiazide diuretics. The examples are benfluoromethazole and indapamide, and they inhibit the sodium chloride importer, but present in the distal convoluted tubule. Earlier loop diuretics acted on the thick ascending limb, These things act on the DCT, and they are indicated in hypertension, hypercalciuria, nephrogenic diabetes insipidus. Okay. These are the two categories of drug: bendroflumetazole and indapamide. And these are the various electrolyte abnormalities: hypomagnesemia, hyperuricemia. All these things can be caused by that. Then the third category is potassium sparing diuretics, or also called as aldosterone antagonists. And the example is spironolactone and aldactone. It's also another component which is available. And they block the action of aldosterone on the distal convoluted tubule or collecting ducts. And primary and secondary hyperaldosteronism, which is resistant to and resistant hypertension in all these things. And also we use that in another important condition. Can you tell me that, other than the cardiovascular system, in which condition we prefer to use aldactone?
DCLD, sir.
DCLD, very good. Liver diseases, cirrhosis liver, excellent. So spironolactone is given in doses of 25 to 50 milligram. It is not available as a parenteral preparation. This both aldactone and spironolactone are available only as oral preparation, and these are the electrolyte disturbances. Then there is another group called pteridine derivative amiloride, not very commonly used, but their mechanism is mainly inhibit the sodium entry through epithelial sodium channels in the collecting duct, and this is mainly used as an antihypertensive agent, amiloride, and the dose is 5 to 10 milligram oral. The next category is carbonic anhydrase inhibitor. Acetazolamide is also a diuretic, inhibits the carbonic anhydrase and acts mainly in the proximal convoluted tubule, but mostly used in glaucoma patients. In the ophthalmic surgeons use it very commonly, and it is used for acute mountain sickness. All those going for expedition or high altitudes, they have to be treated at least with this drug for 3 days to prevent not only mountain sickness but also high altitude cerebral edema. It is called HACE, HACE. Is prevented by giving this drug, and they used in metabolic alkalosis to correct the alkalotic state. And it comes in the name of acetazolamide. It's a drug of 250 to 1000 milligram per day, and it is available as an IV preparation also in the oral preparation. And these are all the side effects of the drug. And lastly, the osmotic diuretic mannitol is a very important drug which as a neuroanesthetist many of us will be using it. It increases the tubular fluid osmolality. It is freely filtered at the proximal convoluted tubule by the glomerulus. Once it enters the tubular fluid, because of its high molecular weight, it acts as an osmotic drug which draws more fluid into the tubular lumen from the doesn't allow the reabsorption by the medullary interstitium. So it is most action with the reabsorption of water from the proximal convoluted tubule is prevented by the drug holding it back into the tubular lumen, and it is mainly indicated in raised intracranial pressure or intraocular pressure conditions, and certain neurosurgeries we use it. Patients with tumor brain, we give this as a pre-treatment to have a lax brain intraoperatively, and the dose is 0.25 to 2 grams, not in milligrams. Please remember it is a gram. So 2.25 to 2 gram per kg IV, and it will cause hypernatremia because water is being excreted. It produces mainly water diuresis. So more sodium will be retained in the body. Extracellular fluid will have more sodium, and patient may go in for hypernatremia. So this is how the various drugs act. The carbonic anhydrase decreases the absorption of bicarbonate in the proximal tubule. This leads to retention of potassium in the urine and decreased sodium absorption. So decreased sodium absorption leads to decrease in the reabsorption of water. This is how sodium carbonic anhydrase works. Then osmotic diuretics inhibit the reabsorption of sodium and water, increasing the osmolality of the blood and renal filtrate. Loop diuretics inhibiting the sodium potassium 2-chloride transporter protein present in the ascending loop of NE. They cause reduction in reabsorption of sodium chloride and salt, which causes diuresis. Thiazide diuretics inhibiting the sodium chloride reabsorption in the DCT, and they suppress the sodium chloride co-transporter. Potassium sparing block the entry of aldosterone in the principal cells of the collecting duct and late distal tubule, which prevents sodium and water retention. So this picture is to depict where all these things act, various diuretics. So that, I think, closes the discussion on the basics of renal system. So let's stop sharing my screen.